In my last video, I began to address the mental health industry claim, one which you may have heard replicated by others, that therapy is for everyone. Looking at the thorough analysis offered by Boyve and Faust in their article Iatrogenic Symptoms in Psychotherapy, I highlighted how therapy can negatively impact any potential client, and for a significant number of people, potentially at least 10%, the harms will inevitably outweigh any benefits. To move on, I would also add that one of the key prompts you will likely hear to persuade you to go to therapy, especially, mind you, if family, friends, or loved ones get a strong enough hint that you are struggling in some capacity or are generally unhappy, is, you should go to therapy. It helped me. Interestingly enough, however, at least one piece of research may undermine such a suggestion. Here I will present the article, Why Ineffective Psychotherapies Appear to Work, a Taxonomy of Causes of Spurious Therapeutic Effectiveness, written by a group of 5 researchers from the departments of psychology at Emory University, Binghamton University, Manhattanville College, Georgia State University, and the Department of Psychiatry at the University of North Carolina, Chapel Hill. The article was published in Perspectives on Psychological Science in 2014. In the article, the authors examine 26 causes of spurious therapeutic effectiveness, or CSTEs. Again, I will read bits and pieces of this article at some length, but the short version is that some psychologists and mental health professionals have the tendency to perceive useless or even harmful psychotherapies as effective. Moreover, clients themselves may succumb to this tendency as well. As the authors write, a clinically depressed client obtained psychotherapy. 2 months later, she is free of serious symptoms. Was her improvement due to the treatment? The correct answer is, we don't know. On the one hand, ample data demonstrate that scientifically supported psychotherapies can alleviate many mental health difficulties, so the client's improvement may well stem at least partly from the intervention. On the other hand, as most mental health professionals know, we cannot draw valid conclusions regarding a treatment's effectiveness in the absence of methodological safeguards against errors in inference, such as well-validated outcome measures, randomized control groups, and blinded observations. Yet even seasoned clinicians and researchers can easily fall prey to the error of concluding that a treatment worked when the evidence for this inference is insufficient. They can commit this mistake when evaluating the effectiveness of treatment for a given client, the effectiveness of a specific school or modality of psychotherapy, or both. The error of inferring that a treatment is effective on the basis of inadequate evidence is widespread, understandable, and problematic for clinical inference. We contend that a number of mental health professionals are insufficiently cognizant of the manifold reasons why ineffective or even harmful treatments can appear effective to the unaided eye. Because of this inadequate recognition, some clinicians and researchers may dismiss or minimize the need for evidence-based practice. We do not contend that informal clinical observations of client improvement are never accurate. They frequently are. At the same time, the histories of medicine and psychology demonstrate that subjective inferences of change in treatment, subjectively compelling as they may be, are often mistaken. Here the authors examine what they refer to as overarching cognitive impediments to evaluating therapeutic change, starting with naive realism. Naive realism bears important implications for the evaluation of psychotherapy outcome. It can lead clinicians, researchers, and others to assume that they can rely on their intuitive judgments. I saw the change with my own eyes, to infer that an intervention is effective. As a consequence, these individuals may A. misperceive change when it does not occur, B. misinterpret when it does, or C. both. Naive realism also reminds us of an easily forgotten principle. Change following therapy is not equivalent to change because of therapy, a logical error known as the post hoc ergo propter hoc. After this, therefore because of this fallacy. Confirmation bias. A second cognitive impediment to appreciating the need for controls in psychotherapy research is confirmation bias. Confirmation bias is the deeply ingrained and commonly exercised tendency to seek out evidence consistent with one's hypotheses and to deny, dismiss, or distort evidence that is not. Specifically, confirmation bias can predispose clinicians to attend to the hits and forget the misses, and thereby overestimate the extent to which their interventions are associated with subsequent improvement. Illusory causation. Illusory causation, or the propensity to perceive a spurious causal relation between two associated variables. Because of illusory causation, therapists, researchers, clients, do notice clients here, and external observers may lead to the conclusion that a treatment exerted a causal effect on the client when it did not. Illusion of control. The illusion of control, or the propensity to overestimate our ability to influence events. When interventions are consistently followed by improvement, treatment providers may conclude that they are the active causal agents when they are not. These four broad cognitive impediments may help to explain why some therapists overestimate their positive client outcomes. In this respect, they appear to be no different from professionals in many other fields, including college professors and physicians and political pundits, all of whom tend to hold an overly charitable view of their effectiveness. In a sample of 129 therapists in private practice, 26.4% psychologists, the average clinician rated him or herself at the 80th percentile of all therapists in terms of effectiveness and skills. 25% of respondents placed themselves at the 90th percentile. None rated themselves as below average. Again, this is a case where the math does not math. Moreover, the typical therapist in the sample estimated the rate of clinical deterioration in his or her caseload to be 3.7%. In fact, numerous studies have indicated that about 10% of clients become worse following psychotherapy. This was also noted in the previous article I read through. Other evidence dovetails with these results. In a sample of 49 psychotherapists in college counseling centers, clinicians markedly overestimated their rates of positive client outcomes, 91%, relative to their actual positive outcomes, 40%, as ascertained by a standardized symptom measure. Furthermore, although therapists predicted that only 3 out of a total of 550 clients, 0.5%, in their collective caseload would deteriorate, outcome data revealed that 40 or 7.3% did so. Taken together, these findings suggest that many or most psychotherapists perceive improvements in clients in their absence and fail to perceive deterioration in their presence. Now, this is an overall view, but the authors expand their discussion to a full list of 26 causes of spurious therapeutic effectiveness, and this is some of the description from those. Palliative benefits. Psychotherapy sometimes makes clients feel better about their difficulties, but exerts little or no effect on these difficulties. Echoing this point, Albert Ellis underscored the importance of distinguishing feeling better from getting better in psychotherapy. For example, an antisocial client may enter therapy distressed about his repeated marital infidelity and leave therapy less distressed, but with an unaltered risk for future infidelity. As Albert observed, therapy sessions can work like spa appointments. They can be relaxing, but don't necessarily help solve problems. Confusing insight with improvement. Some clients may achieve greater insight into their difficulties over the course of therapy. Although such insight may not be linked to improvements in objective treatment outcomes, clients may believe that they have achieved progress merely because they can now conceptualize and verbalize their problems in greater richness and detail. Retrospective rewriting of pretreatment functioning. In some cases, clients may persuade themselves that they have improved by misremembering their initial level of functioning as worse than it was. Selective attrition. Selective attrition refers to the fact that clients who drop out of therapy are not a random subsample of all clients. Research demonstrates that clients who are not improving are especially likely to leave psychotherapy. As a result, therapists may conclude erroneously that their treatments are effective merely because their remaining clients are those that have improved. One problem that has long bedeviled the evaluation of Alcoholics Anonymous and similar 12-step interventions for substance disorder is the high-level client dropout from this intervention, often approaching 40% following 1 year. The clients who remain in these treatments after several years are generally faring better than when they began, but they are unrepresentative of the clients who initially enrolled. The clients who dropped out may not have been helped or may have even been harmed by the intervention. Spontaneous remission. Spontaneous remission refers to the tendency for disorders to resolve on their own. Early reports by Eysenck of spontaneous remission rates of 70% or more among psychiatric patients were almost surely overestimates. Nevertheless, later data point to non-trivial rates of spontaneous remission in outpatient samples. For example, Pasternak and Zimmerman reported a spontaneous remission rate of 52% among patients with major depressive disorder. The rates of spontaneous remission among children and adolescents with psychopathology, including behavioral problems, approach or exceed 40%. The longer people remain in therapy, the greater the opportunity for extra therapeutic factors, including natural healing processes, coping, social support, and positive experiences in everyday life to contribute to observed or perceived improvement. Moreover, when frequent spontaneous remissions happen to coincide with the administration of specific interventions, client and clinician alike may fall prey to illusory causation, coming to believe that the interventions are producing the spontaneous remissions. Spontaneous remission may be partly accounted for by what Alexander and French termed the corrective emotional experience, a positive affective occurrence that ameliorates the detrimental impact of early negative life events. Although Alexander and French emphasize the role of corrective emotional experiences in psychotherapy, such as finding a loving partner in the aftermath of an abusive relationship, surely occur in everyday life as well. In the words of psychoanalyst Karen Horney, life itself still remains a very effective psychotherapist. The problem, however, as I would argue, is that therapy is becoming a substitute for life. This can be seen in the prompts I have already cited that you should not talk to family about problems because they might be experiencing symptoms of mental illness themselves, and that the therapist is better equipped to just be empathetic and listen, and more on the empathetic part later. History. A related extra therapeutic factor that can contribute to the erroneous inference of a therapeutic effect is what Campbell and Stanley termed history. Widely shared events transpiring outside of the treatment setting. A client who is experiencing severe life stressors due to a poor economy or recent natural disaster may improve when the impact of these events on his and his friends and loved ones' financial and personal life has dissipated. The clinician may erroneously attribute improvement during therapy to the treatment itself rather than to the salubrious changes in clients' everyday life. Initial misdiagnosis. Even the best trained diagnosticians are fallible. For example, relatively normal individuals undergoing temporary life stressors are at times mistakenly diagnosed as psychopathological. When they are later examined, they have improved, but not necessarily because of the treatment. Effort justification. Because clients often devote substantial time, energy, effort, and money to treatment, they may feel a need to justify this investment. They may do so by persuading themselves that therapy was beneficial, a phenomenon termed effort justification. Calling back to the article Iatrogenic Symptoms in Psychotherapy I discussed last time, and how the therapist often remains ignorant of how their own treatment might cause harm, the authors here in Why Ineffective Psychotherapies Appear to Work also highlight the lack of coverage of these issues in graduate courses in the mental health professions, as well as in continuing education courses. But in short, there are many reasons why the therapist or the client themselves may believe ineffective or even harmful treatment is effective. One thing I would emphasize as well is that these researchers consistently highlight the important role social support can play in the very issues someone might be compelled to see a therapist for in the first place. However, increasingly, it seems as if we would rather push the people in our lives that we could be supporting, often easily, in their issues off on therapists. As family members, friends, or loved ones, perhaps we should try to do our part to be supportive before pushing the people in our lives off on these professionals. Therapy is not harmless, and if you think it is acceptable to push people off in such a manner because you got help from a therapist, try to realize that just because you got the help you wanted or needed does not mean someone else will. Indeed, if you have the capacity for it, you may also want to take a long look at whether you got help at all. And I will leave it at that until next time. I hope to see you there.